moving right along here, that is it for our glomerulonephritis, our nephrotic syndrome, our nephritic syndrome. What questions do you have? You know, just kind of like looking over your first aid book and or whatever notes you've taken. Anything you want me to go over again? Anything that didn't make sense? You know, if it comes up over the weekend or something, that's fine too. You can always shoot me an email or just tell me when we meet on Monday, and I'll be happy to go over it. But for right now, is there anything that's just kind of like glaring in your face? Can you repeat what you said? Sure. So let me just kind of get all of my chicken scratch out of there. And so for rapidly progressive glomerulonephritis, what we're looking for is a rapid or quick increase in the damage being done to the kidney. So normally inside of our glomerulus, what you can see is the blood vessels take up the entire space. Right, we have all of our blood vessels here really taking up the whole space inside of our glomerulus. In rapidly progressive, we start having a lot of inflammation that causes fibrin and other debris, other waste to be put down in that area. And so what you end up seeing is on this, take this glomerulus for example, the glomerulus is only occupying a small space of this. The rest is all of this inflammatory tissue. This is fibrin. This is all sorts of just useless material that's crushing in on our glomerulus. You can think of it kind of like scar tissue that's forming in this area, and it's just useless debris that's pushing in on our glomerulus. You see the same thing here. Here's our glomerulus, and here's all that extra tissue that's being put down. This is very bad because as you compress on the glomerulus, now blood is not going to be able to easily get to the glomerulus. We're not going to have filtration over that basement membrane. We're not going to be able to clear things out of our body. And so we end up with this necrosis and crescents, rupture of the glomerular basement membrane, big problems in rapidly progressive. To identify it, because I do think you'll need to identify it, what you use to identify it is look for your glomerulus and then see if you can kind of, in your mind, draw a crescent in that glomerulus. Or a croissant. Again, if you're into French pastries, you can draw a croissant as well. Okay, here's our croissants here. Okay, so that's what we look for rapidly progressive. There's 3 types. Type 1 is Goodpasture's disease. Goodpasture's disease. Those patients are going to present with hemoptysis as well as hematuria, blood in their sputum, blood when they cough, as well as blood in their urine. That is due to an antibody that binds the basement membrane. Okay, so it is a basement membrane antibody. And that antibody is the reason that you're having blood in the urine. Because when that antibody binds to the basement membrane, it's going to destroy the basement membrane. Now blood can pass into the urine. That antibody is also the reason that you have blood in the cough, blood in the sputum. Because the basement membrane in our alveolus is also being attacked, and blood is then crossing over into the alveolus. When your patient coughs, that blood comes out. So that's our Goodpasture's disease. That's for our type 1. Type 2, I wouldn't really worry about because it's sort of a mixture of a bunch of different diseases. Type 3 is for things like Wegener's, which Wegener's has a new name. I don't really know the name. It has some weird name. And then our microscopic polyangiitis. And then some of our other syndromes that are found with ANCAs. You know the ANCAs, right? Like C-ANCA, P-ANCA, things like that. And so, so those diseases affect the kidneys in this way, with a rapid progression, a destruction of the glomerulus, with all of this extra tissue and debris left behind. Okay? Any specific questions on this one? No? Okay. Great. So next we're going to move into acute tubular necrosis. I just have to run and grab a cup of water. I'm getting a little bit parched here. I don't know if you can tell. And so I'll be right back, okay? Hello? Hello. Okay, good. So let's continue on here. Acute tubular necrosis. This is a acute renal failure. Okay, and the important thing here, and what they like to ask about on your step one, is that acute tubular necrosis goes through stages. This is, I'm going to put a star right here because this is really where they love to pick something to ask you questions about. And so the first stage is where the damage is first happening. It's the first 36 hours after you have that damage to your kidneys. You're going to have a drop in your urinary output, and the BUN levels are going to increase. Now, after that, you move into stage 2. Here, you have a huge decrease in your urinary output. Only 40 milliliters a day, right? How much is 40 milliliters? Like this much, right? Very small amount of urine being excreted each day. Because the kidneys are not working during this phase, you're going to have overload of sodium and water, elevation in BUN, high level of potassium, metabolic acidosis, uremia. Imagine your patient has 0 kidneys, and that's how you can understand phase 2. In the recovery phase, as the kidneys are sort of regaining their function and coming back to normal, what you see is a huge increase in urinary output, up to 3 liters per day. And so, the kidneys, they maybe felt bad for not doing their job for a little while. Now they kind of overdo it. And so here we have up to 3 liters of urine per day and low potassium. Okay, they kind of overdo it, and you really get a drop in your potassium level. Okay. Pretty good recovery in patients as long as they get supportive care. Okay, and so make sure that these patients are on IV. You're monitoring their potassium levels, making sure it doesn't get too high, and things of that nature. Okay, and so in terms of questions about acute tubular injury, just keep in mind during the initiation phase, you have a small drop in urinary output. Following that, it's maintenance phase where you have a huge decrease in urinary output where you're really just peeing a few drops per day. And then in stage 3, your urinary output goes through the roof and you're actually putting out 3 liters per day. Okay, so that's quite a bit. That's the most important thing I think you need to know for step 1. Just kind of going through the pathogenesis here. Our epithelial cells, think about inside of our nephron. Here is our descending, ascending. Here's our descending, ascending. Great. And so the cells that are inside of this tubule, these are the guys that are absorbing all of that sodium. They absorb sodium, they absorb amino acids, they absorb glucose. We said the proximal convoluted tubule is a magical place because we have all these cells that are working hard, getting the job done. However, if you have some patient that has a drop in blood pressure, these cells can become ischemic, right? They can start to die off. If you have some sort of toxin, you take something that's toxic to the kidneys, these cells are going to feel it. Think about your aminoglycoside antibiotics. Aminoglycosides are very nephrotoxic. If you give that to your patient, there's that risk that their kidneys can be damaged by that. And so the first thing that's happened is going to be these cells dying. Okay, that results in increased sodium delivery to the distal tubule. So now sodium is going to be more delivered here. This results in vasoconstriction, more cytokines. We have obstruction of the tubules, an overall drop in GFR, and ultimately we are going to have a disturbance in our blood flow and a disturbance in our GFR. The amount of fluid going into our kidneys is going to fall, and that is sort of how acute tubular necrosis happens. Okay. And so if we have some ischemic injury, your patient gets hypovolemic, they have a heart attack with very little cardiac output, look for patchy necrosis. Necrosis that's happening here, there, everywhere, but not continuous. In toxic injury, when we take an aminoglycoside medication like amikacin, for example, this would be continuous necrosis where all of the kidney is damaged instead of patchy necrosis. Okay. Any questions on this one? No. Okay, great. Pyelonephritis. This is a classic, right? This is going to be our ascending bacterial infection. It comes up from the bladder, goes through the ureter, and starts affecting the kidney. Sudden onset of pain at the costovertebral angle. What is this costovertebral angle? Have you heard of this before? So the costovertebral angle, the way to check for pyelonephritis essentially is you're going to have your patient sit down in front of you and you're going to ask them to turn around so that their back is facing you. Okay? Now, you're going to put a finger on their spine and you're going to feel down their vertebrae and you're going to go down their vertebrae until you get to the very last rib. Okay, and so if this is the vertebrae, here's their rib. Okay, and this is the very last rib. Here's the rib above it, and the rib above it, and the rib above it. So you're going to get to the very last rib, and the angle between that last rib and the vertebrae is your costovertebral angle. That's what that is. The angle between the very last rib and the vertebrae. Okay, and so in order to check for tenderness there, you put your palm on that angle. And then you put your palm on that angle and then you pound on your hand like this. If your patient is having pain in that spot, that tells you that they have pyelonephritis, okay? Excuse me. Thank you. And so this is the way that you check for pyelonephritis, okay? Does my diagram look like anything to you? Does that, I mean, it's kind of a pretty crappy drawing. But hopefully that description makes sense. You know, you can kind of feel on yourself if you go put your hands back behind your back like this, where the last rib is, and then just follow that rib to where the vertebrae is. And so that spot where the last rib is meeting the vertebrae, if you just go down about 2 centimeters, that would be the spot that you would want to pound on for your patient's back to check for pyelonephritis. Okay? Okay. So fever and malaise. Look for the symptoms of UTI. Pyelonephritis, an infection of the kidneys, almost always happens in a patient who has a UTI. And so look for everything that you see in UTI. Increased frequency of going to the bathroom, pain when urinating, feeling like they have to run to the bathroom. That's what urgency is, right? They feel like they have to run to pee, otherwise they're going to have an accident. And then when we look for casts, oh my goodness, white blood cell casts. White blood cell casts. If they tell you that there's white blood cell casts, you really better be thinking about pyelonephritis, okay? If you don't think about that, I'm going to pop out of somewhere and karate chop you, okay? I'm going to karate chop you right in the costal-vertebral angle. So, white blood cell casts, pyelonephritis. Why? Because the white blood cells are there to fight off the bacteria. Okay? So, again, an ascending bacterial infection. Most common cause of UTI is E. coli. And so that should be what pops into your mind as a possible, as the possible bacterial cause of this condition. You should think about E. coli. It's one of those natural flora of the GI tract. You know, if you're not using proper hygiene, that E. coli can get from the GI tract up to the urethra, and from there go straight into the bladder. Okay, and so papillary necrosis. Other diseases have papillary necrosis as well. You see this triangle here? This is papillary necrosis. Some other diseases that have papillary necrosis: diabetes, sickle cell disease, and analgesic nephropathy. When you have a patient that takes too much aspirin or too much of the other NSAIDs, they can get papillary necrosis as well. And they sometimes ask you about causes of papillary necrosis, so it's a good idea to make a flashcard or make a little note about this particular connection, papillary necrosis and these diseases, especially sickle cell disease. I think they ask about the most. Okay. If they were to show you the light microscopy, I doubt that they would, but if they were to show you, look for lots of neutrophils, okay? And so you can see an aggregate of neutrophils here. How would you know these are neutrophils? You wouldn't. They would have to tell you. But if they told you that there's an abscess of neutrophils in the kidneys, hopefully you're thinking about pyelonephritis, and you know, and you can make that connection there. So one of the causes of pyelonephritis, especially in men, is a vesicle ureteral reflux. Okay, and so in general, men don't really get UTIs. Okay, do you know why UTIs are more common in women than in men? Yes, exactly. The length of the urethra is shorter in women, and so the bacteria, if they're able to get to the front of the urethra, it's very easy to get into the bladder. Just like you said, it's just an anatomy. And so when you see a UTI in a man, it means that there's probably something else going on. They could have a low immune system, they could have something wrong with their anatomy. And one of those things that could be wrong with the anatomy is this vesicle ureteral reflux. And so essentially it's incompetence of a valve that allows bacteria to go from the ureter into the renal pelvis. And so, you know, this could just be congenital. It can be after you have a lot of bacterial infections, some sort of spinal injury causing your bladder not to contract anymore. These are the sorts of things that can allow for urine to reflux backwards into the ureter. In general, urine should only come down in this direction. However, if you lose this valve, if this valve is not strong anymore, now urine can go backwards, and it increases your risk of pyelonephritis. Okay, great. So chronic pyelonephritis is when you have recurrent episodes of pyelonephritis rather than just the acute. It looks a little bit different as well. As you can see, the kidneys themselves here, they kind of have this appearance of, you know, someone just kind of took a chunk out of it, right? It looks like someone used, you know, just their thumbnail and just kind of took out a little bit of that, that kidney skin there. So irregular scars, you know, flattened papillae, usually in the upper and lower poles. These are what you see on gross anatomy. When you look under light microscopy, you have something that's called thyroidization. Thyroidization means that it kind of looks like thyroid material. If you remember when we did thyroid in our endocrine section, we talked about how you have the follicles that are filled with your thyroid hormone, and then there's cells around them that eat up that follicle material. And so when you have chronic pyelonephritis, the appearance looks like thyroid tissue. It doesn't make thyroid hormone. That's not what that means. It just kind of looks like that. Okay, so don't get it twisted that I'm saying that the kidneys turn into thyroid glands. That's not what I'm saying. I'm saying when you look under a microscope, it kind of looks like thyroid if you took a biopsy from the thyroid gland. It's called thyroidization. I didn't make this up. I did not make this up. It's something that you can see in chronic pyelonephritis. Interstitial nephritis. This is one of the other cases where you can have white blood cell casts. White blood cell casts you will either see in pyelonephritis or interstitial nephritis. And so what is interstitial nephritis? Typically, it's 15 days past exposure to some sort of drug that your patient is allergic to. Those drugs can be antibiotics like methicillin, ampicillin, rifampin. Could be your thiazide diuretics, hydrochlorothiazide, your NSAIDs, aspirin, ibuprofen, anything like that. Just sort of causing some inflammation of the kidney. Okay, and so under light microscopy, just you'll see edema, and the cells that you see here are eosinophils. And so if they're telling you that there are eosinophils in the kidney, think about allergic interstitial nephritis. Think about your patient's having an allergy, right? It's eosinophils, you have to have that association with allergies. Eosinophils and allergies go together. And so if they're telling you that there's eosinophils in the kidney, think about this condition. Your patient has taken some drug that has caused an allergic response, and that's why they're having the problems that they're having. Okay. NSAIDs can cause a lot of different problems in the kidneys. You can have acute kidney injury, hypersensitivity leading to interstitial nephritis, like we talked about up here, acute interstitial nephritis, minimal change disease, like we see in children, membranous nephropathy. NSAIDs can cause a lot of big problems in the kidney. Just sort of always remember, always keep that in mind with a patient with a kidney problem. You want to ask them about their NSAID use. Light chain cast nephropathy. This is in our multiple myeloma patients. Okay, and so for multiple myeloma, there's 4 main symptoms that you need. They're called the CRAB symptoms. In multiple myeloma, you have increased calcium, you have renal issues, renal problems, you have anemia, and you have bone fractures. Okay, we're going to talk about multiple myeloma when we get to our hematology and oncology section, which is starting next week. Oh my God, I can't believe we're already there. We're going to talk about multiple myeloma, and we'll talk more about it essentially. But in multiple myeloma, essentially you have tumors, B-cell tumors, inside of the bones. And so these tumors, they are going to be breaking down bone to increase your calcium. The B cells are going to be eating up your red blood cells, causing anemia, bone fractures because the tumor is in the bone. And in the level of the kidney, multiple myeloma is going to be a B cell that releases a large level of something called a light chain. Light chain. And these light chains are little bits of protein. When those little bits of protein get to the kidneys, we can actually have some damage when those light chains get to the kidneys. It's going to present as chronic kidney disease. And so how do we check for that? It's called Bence-Jones proteinuria. All that means is just seeing those light chains in the urine. Those light chains, as they go through the tubules, are going to get stuck. Okay, and ultimately when they get stuck, they cause an inflammatory reaction and ultimately cause tubular injury. Okay. Great, and so we can see some amyloidosis. Amyloid is always going to be secondary to when you have a lot of proteins lingering around in one area for a long time. And so that's something that you could definitely see here. Okay. Any questions? Again, we'll talk more about multiple myeloma when we get into our oncology section, okay? Nephrosclerosis is essentially damage to our kidneys in patients with hypertension. Patients with hypertension. And so sclerosis of renal arterioles and small arteries. Essentially, normally we have these nice big arterioles which are eventually going to get into the glomerulus and ultimately going to leave the glomerulus as the renal veins, right? They're nice, big, wide open arteries. In nephrosclerosis, we have a narrowing of these arteries. Okay, so the arteries become much more narrow, and so less blood is able to get to the glomerulus. If less blood is getting to the glomerulus, you can imagine all the things that happen. So, the kidney has a lot of ways of detecting low blood pressure. If less blood is getting to the glomerulus, the kidney's going to think your blood pressure is low. So it's going to activate the RAAS system that you told me about really nicely last time. And so when you activate the RAAS system, it's going to cause further hypertension. More hypertension is going to cause these arteries to get even more narrow. Now, even less blood is getting to the glomerulus. Now, the RAAS system is getting activated even more. And so you have this very dangerous, vicious cycle where high blood pressure is causing narrowing of an artery. That narrowing of the artery causes the kidneys to increase the blood pressure. Now you have a higher blood pressure and more narrowing, and it just sort of goes around in a circle like that. Patients that are at high risk of nephrosclerosis, Africans with hypertension, kind of interesting population, elevated blood pressure, and diabetes. Okay. The way the kidney looks, it's described as kind of a football kidney. Okay, this is not, European football. This is American football, and so you've seen American footballs. They kind of have those little tiny bumps on them, right? And so the kidneys kind of take that appearance. You can kind of see in this picture lots of tiny little bumps on the surface of the kidney that kind of looks like an American football. Okay. On light microscopy, you can see hyaline arteriosclerosis. Essentially, this is a blood vessel, right? This is the outside of the blood vessel. The only area for blood to flow in this vessel is this little area here. All of the rest of this is thickening of the outside of the artery. All of this pink out here is all just thickening of the wall. And so you can imagine that is really going to reduce blood flow to the kidney. The kidney is going to respond by increasing the RAAS system, and the pressure is just going to continue to get higher and higher. Okay. Questions on this one? Okay. So, as that problem gets worse and worse and worse, you can actually have a malignant nephrosclerosis. And so whenever you have a patient with hypertension of systolic pressure over 200 or diastolic over 120, we call that malignant hypertension, right? When you have 200 over 120 blood pressure, that's pretty bad, right? We call that malignant hypertension. We're going to see papilledema, hemorrhages in the retina, encephalopathy with convulsions and seizures, and renal failure. Okay, that high blood pressure is going to start damaging every area of the body. And so what we end up seeing is the kidneys themselves look a bit like they have these little hemorrhages on them. It's called flea-bitten appearance. I don't know what kind of bite fleas make, so this doesn't really mean much to me. Flea-bitten. I've never had fleas. My dog's never had fleas, and so I don't really know what this looks like. But apparently, flea bites look a little bit like this, like little tiny hemorrhages on the surface of your kidney. Have you ever seen flea bites? Do they look like this? Little tiny bites like that. Okay, so I guess that's right then. Little flea bites on the outside of your kidney means that you may have a patient with this kind of blood pressure. Not good. If you take a biopsy and look at the arteries, what you see is onion skinning. You can see this artery, how it kind of looks like an onion. If you cut an onion in half, it has all of those layers. And so that's what we see on biopsy in these patients. Okay? Great. Renal artery stenosis is when we just have a narrowing of the main renal artery. In the previous ones, we talked about narrowing in some of these smaller arteries, right? For our nephrosclerosis, this is narrowing of the smaller arteries, the arterioles inside of the kidney. Now we're talking about narrowing of the main renal artery, the branch of the aorta. What happens when this gets narrowed? Okay, and so when that gets narrowed, essentially you're going to have less blood coming to the kidneys. Renal artery stenosis is going to have an activation of the RAAS system because less blood is getting to the kidneys. When less blood gets to the kidneys think that means that there's a low blood pressure. The kidneys are not too smart, right? And so whenever there's less blood flowing to the kidneys, they automatically assume that's a low blood pressure. Your blood pressure may be fine. It may just be that you have a stenosis. You have a narrowing of the artery, and so less blood can get there. But your blood pressure could be fine. Here, pressure could be fine, 120/80. But because we have this narrowing in this artery, less blood is getting to the kidney's thinking, oh my God, blood pressure is so low right now. I need to do everything to increase the blood pressure. So let's activate the RAS system, our AAS system. Let's just do everything we can to raise blood pressure. And so this narrowing can end up causing your patient quite a bit of hypertension. If you're able to go in here and place a stent so that blood can start to flow better, this patient's hypertension will go away. Now this kidney is happy, it's getting enough blood, it's going to deactivate the RAAS system, and your patient will live happily ever after. Okay. Now, if your patient is having renal artery stenosis and happens to be a young female, think about fibromuscular dysplasia. Fibromuscular dysplasia is where you have essentially the muscle in the walls of the arteries starts to grow too large and narrows arteries. Okay, it's a condition that really only affects women, and it's relatively rare. But in terms of USMLE, you never know what they're going to throw at you, right? These guys are crazy. And so if you have a young female with renal artery stenosis, think about fibromuscular dysplasia. That's the only reason a young female should have narrowing of the renal artery. Otherwise, it's like some old man who has a plaque here, right? If it's a young woman, you should think about this condition. Okay, great. Polycystic kidney disease. Two types of polycystic kidney disease. We have adult polycystic kidney disease, which is the autosomal dominant type, and we have the pediatric or the neonatal polycystic kidney disease, which is our autosomal recessive. Okay. So for the dominant, this is a patient who's lived their whole life without realizing they had a kidney problem, and then once they hit age 60 or 70, their kidneys start to look like this, right? Not good. So this is pretty common. A lot of these patients are going to be asymptomatic until they start to have renal insufficiency. They may see blood in their urine. They may have pain. The clots can cause renal colic, where you have pain come and go. And eventually this is going to end in end-stage renal disease. Okay, and so the reason for this polycystic kidney disease is for this polycystic kidney disease 1 gene and polycystic kidney disease 2 gene. Okay, so these are going to be easy to remember. I hope you can remember these if you get this in a question on your step 1 exam. Autosomal dominant mutation in polycystic kidney disease 1 or 2 genes. Okay, and so look for enlarged massive kidneys on both sides. And that's kind of like what you want to be able to see. It's also important to have the connection of these patients having subarachnoid hemorrhages with the Barry aneurysms. With a Barry aneurysm, essentially you have a increase in size, an aneurysm in your circle of Willis in the brain. The blood vessels in your brain, essentially you get an aneurysm there. And there's a strong connection between these Barry aneurysms and polycystic kidney disease. And so these patients will either die from renal failure or die from a subarachnoid hemorrhage, a stroke, essentially a hemorrhagic stroke in the brain. Questions on this one? Okay. For our childhood polycystic kidney disease, again, we said this is the autosomal recessive form. And so this is most common in perinatal and neonatal forms. So here we have renal agenesis, essentially. The kidneys do not develop properly. Because of this, the fetus is not going to be able to generate the amniotic fluid. And so there's going to be oligohydramnios, low levels of amniotic fluid. And the lungs are not going to develop as well. Essentially, this has a very poor prognosis, unfortunately. Very sad. It is autosomal recessive, so there is hope for parents who, give birth to a child with this disorder that it's possible that the next child may not have this disorder. But again, it is quite sad. It is a quite sad diagnosis. Okay. Any questions? Most important thing to remember is that the childhood version is autosomal recessive and the adulthood version is autosomal dominant, because they'll try and trip you up on that sometimes. Okay. Simple cysts, very normal cysts. Sometimes you will see these when you're doing an ultrasound of the kidney. It can cause distension and pain, but in general, you don't even really treat these. If it's a small one like this, you wouldn't really treat it. This might cause some pain, and you can go in with a needle and drain it. But in general, cysts can happen on the kidney, and just sort of unlucky if you get them. But it's not going to be any sort of death sentence by any means. Patients with sickle cell can have damage to their kidneys as well. They're going to present with hematuria, blood in their urine, a decreased ability to concentrate their urine. They should have a very dilute urine. And again, we said sickle cell nephropathy is associated with papillary necrosis. It's important to know the things that cause papillary necrosis. The other one we said was our the other one we said was when we have the infection of the kidneys, which is, must be late, I don't know. When we have the infection of the kidneys, it goes from a UTI, it goes up to the kidneys and causes pyelonephritis. So pyelonephritis, you can have papillary necrosis, and in sickle cell disease, you can have papillary necrosis. I just had a minor brain fart there. That was embarrassing. So just sort of have that connection in mind. With sickle cell and with pyelo, you can have papillary necrosis. Okay. And so here's sort of that picture of papillary necrosis from before. You can see all of these white areas are sort of the papillary areas, and they are all dead. So we call that papillary necrosis. It's associated with pyelonephritis, we said, sickle cell disease, use of NSAIDs, and diabetes mellitus. And so the way you can remember this is SAD PAPA with papillary necrosis. So SAAD stands for sickle cell, acute pyelo, analgesics like NSAIDs, and diabetes. SAD papillary necrosis. Okay. Great. Renal cell cancer, a very important cancer to talk about, and it is not a cancer you want to get. So it's a malignant neoplasm of the kidney. Patients are going to present with that costovertebral pain, that pain we talked about that you see in pyelonephritis. However, when you're pressing there, you're going to feel a mass. In pyelonephritis, you would not feel a mass. All your patient would say is, Dr. Aguilera, can you stop banging on my back, please, right? But if you are back there banging on the patient's back and then you can feel a mass back there, that should point you towards some sort of cancer. And there's also going to be blood in the urine, okay? And so it can be a clear cell carcinoma or papillary carcinoma, but essentially they're all from the kidney. Tobacco is the most significant risk factor. If you smoke cigarettes, it really increases the incidence here. Other things, obesity, hypertension, asbestos, heavy metals, some other random stuff can increase your risk of this. And big thing that you'll see here is that the cancer will start to invade the renal vein. And so we have our kidney, and we have the renal artery coming in from a branch of the aorta, and then we have the renal vein that's going to go back to the IVC. This cancer growing loves to go into the renal vein, okay? And it's going to start to block off the renal vein. So a lot of times your patients are going to present to you once this has already happened, because once you block off that renal vein, that is going to cause a lot of pain for your patient. It's going to cause a lot of blood in your patient's urine. Okay, and so that's one thing to definitely keep in mind in terms of presentation, is that there is an invasion of the renal vein by this cancer. Renal cell carcinoma travels through the body via the blood, and so you can see metastasis to the lungs. Okay, most of the time it's going to be in the lungs. For your clear cell type on light microscopy, you're going to see these big balloon cells with very clear cytoplasm. It's called clear cell, and they look pretty clear. For your papillary, not too much you can really see on papillary except for these psammoma bodies. Okay, and so there's some psammoma bodies here. Okay. Any questions on this one? No. Very, very bad cancer to have. It's really, your patients are not really going to know that they have it and it's growing until it starts to cause problems. And usually when it's causing problems, it might be too late. And so it's an important one to talk about. Urinary tract obstruction. So here we have an obstruction of our urinary tract that is going to lead to distension of the kidney itself. When you distend the kidney, this is called hydronephrosis. Okay, and so if it's an acute obstruction of the urinary tract, you're going to have pain, and this pain is due to that hydronephrosis, that growth of the size of the kidney. So what sort of things can cause an obstruction? Think about kidney stones, right? If you have your kidney here, and you have the ureter coming out, draining all the urine, if a stone forms somewhere in this ureter, the kidney is going to keep on creating urine. And so that pressure is going to start to build up back in the kidney until the kidney starts to get stretched out and looking like this. Okay, so that's one of the most common causes. Also, patients with benign prostatic hyperplasia, where you have a growth of the prostate, that's going to block the urethra. So you'll have increased pressure in the bladder. That pressure will be transmitted into the ureters and then transmitted into the kidneys as well. Chronic obstruction, inability to concentrate urine, kidney stones, hypertension, these are the types of things you see there. If it's unilateral, if it's only affecting one side that you have this kidney problem like this, usually that's a stone. Typically stones are only on one side. If it's on both sides, think about a problem like benign prostatic hyperplasia, where the pressure is building up in the bladder, and so that pressure is going to go up both sides. It's going to go up into both ureters and cause problems in both kidneys. Okay? Great. And so acute, we will see that dilation. You may see a little bit of atrophy. With chronic, you get permanent atrophy, permanent death of the kidney cells. With chronic obstruction, you can also see the thyroidization that we talked about in chronic pyelonephritis. We talked about thyroidization, that the tissue starts to kind of look like thyroid tissue with little follicles and what have you. That kind of looks like thyroid tissue. Okay, so any kind of obstruction to the urinary tract can lead to hydronephrosis, and that's the most important thing there. Urolithiasis, nephrolithiasis, kidney stones. So stones can be found anywhere in the urinary system, from inside of the kidney itself to in the ureter to even in the bladder you can form stones. They could be asymptomatic. However, most of the time you're going to have something called renal colic. This is a pain that patients are going to report some abdominal pain that radiates into the groin. Abdominal pain that radiates into the groin is going to be kidney stones 9 times out of 10. If they put that in the question stem, think about kidney stones. Abdominal pain that radiates downwards into the groin. The treatment is really going to be prevention. Drinking a lot of fluids, dietary changes. If they have a stone, a lot of times we just wait for them to pass it. If it's a large stone, we may try and break it up. Okay. If they ask you what kind of dietary changes, if they're taking calcium supplements, stop that. Stop any kind of spinach and kale, and reduce the sodium. Believe it or not, reducing sodium is going to reduce your chance of calcium stones. I know it doesn't really make a lot of sense. What does sodium have to do with calcium? But this just happens to be the way the human body works. If you reduce the amount of sodium in your diet, that's going to reduce your risk for calcium kidney stones. Okay. So calcium stones are going to be most of your kidney stones. If you see this word struvite or magnesium ammonium stones, think about a infection with Proteus mirabilis. Okay, this is a particular bacteria that causes UTIs. If Proteus gets up into our kidneys, it forms these particular kinds of stones called struvite magnesium ammonium phosphate stones. Those stones can actually take up the entire kidney space, causing a staghorn calculus, where it kind of looks, you know, a stag, like one of the male deers. They have all of those horns. That's kind of how the stone looks, because it's taking up the entire renal pelvis, that if you look at your kidney, the stone is actually poking into every single area of the renal pelvis, okay? And so all of this is your giant kidney stone. We call that a staghorn calculus. And this is really only caused by Proteus mirabilis bacteria, because they have this urea splitting enzyme. Okay. Patients with hyperuricemia can develop uric acid stones. Any cause of high uric acid can lead to uric acid stones. And so you think about your loop diuretics cause high levels of uric acid. You can think about, I guess loop diuretics are the main things that cause high levels of uric acid. And so, but really anything that causes high levels of uric acid can lead to uric acid stones. Okay. One thing we need to be aware of is that having these stones is going to increase your risk of pyelonephritis, a kidney infection with bacteria, by a lot. Okay. If there's stones there, bacteria are going to love going in there and finding a little home for themselves. Okay. Great. And a renal infarct is where you have essentially like a stroke of your kidney. Right? And so you have some sort of embolus that goes down into the renal arterioles and blocks the blood supply from going any further, and you end up with this wedge-shaped infarct. Wedge-shaped infarct, where it's all dead material back here because of some sort of embolus. Okay. And so a lot of them are going to be clinically silent. Sometimes your patients will report pain at the costovertebral angle. They're going to report a little bit of blood in the urine, and so great. That's what you would look for. Okay, pretty straightforward diagnosis there. Okay, and so great. So we can work through some questions together. I know this is what you were looking forward to. So the first question here, the following information was obtained in a 20-year-old college student participating in a research study in the clinical research unit. And so we have the plasma concentration of inulin, plasma concentration of X, urine concentration of inulin, urine concentration of X, and then the urine flow rate. Okay, so I'm thinking that this is some sort of clearance type problem, right? Assuming that X is freely filtered, which of the following statements is most correct? There is secretion of X, there is reabsorption of X, there's reabsorption and secretion of X. The clearance of X could be used to measure GFR. Clearance of X is greater than the clearance of inulin. Okay, and so I haven't done this problem for a while, so I'm going to pull out a piece of paper. I'm going to do it right now, and then you can do the same. If you're not sure what to do, let me know, and we'll work through it together, okay? You already finished? Did you already finish? Oh, okay. So, sorry, go ahead. Sorry I interrupted you. I'm so sorry. What were you saying? You're not sure? Okay. So, what did you get for your clearance of inulin? That's the thing? Okay. Good. Good. Yep. Good. So it's a clearance of inulin. What about the clearance of this X substance? So, yeah, you do all the same stuff. Yeah. Good. So, now we know the clearance of this substance X is less than inulin. And inulin, clearance of inulin is equal to what? Excellent. Good. So, if the clearance of this substance is less than the GFR, what must be happening? Why is the clearance of this substance less? Nailed it. Yes. Very good. There's net reabsorption of X is the correct answer. Very good. So just really just sort of applying what you know, and your understanding of this stuff is very, very good. Literally, I did not help you on this question. You realize that, right? You thought you were doing it wrong. You were doing it right. No, you gave me all the numbers. I just filled it in. And so, very good. Net reabsorption of X. If there was net secretion, then the clearance of X would have been greater than inulin. Reabsorption and secretion, there's no way to know this, right? Like how could you possibly tell? No way to know that, so that one's out. The clearance of X could be used to measure GFR. No, because it's less than inulin. And clearance of X is greater than inulin. No, that's not right either. So great, excellent, very, very good, very, very good. Any questions on this one? Not now. Yeah, you know it. You knew it before. You know before. You got to trust yourself, okay? Yeah, I see that. I see that. You shouldn't, though. You shouldn't. You got to have that confidence because that is really the biggest part of doing well on this exam is knowing when you go in that you're going to kill it. Knowing when you go in, it's mind over matter and just kind of telling yourself, I've studied for this exam for long enough. I've done so many damn UWorld questions. I know enough to do well on this exam. And then answering questions with that attitude that whatever I put on this question, it's probably the right answer. Whatever I feel like is the right answer, that's probably the right answer because I've been studying long enough, I've put the work in, and what comes next is you passing step one and getting a really nice score, and then and being a great doctor. So, great. Mm-hmm. Hello? Right, did you say D or B? Definitely the right answer. Yeah, excellent. Very good. Yes. Did you calculate these other ones? Or did you just go right for it? Good. Good. Very good. Oh my God, that's true. Okay, so I think I got this question wrong. So you're absolutely right. So I didn't read blood flow, I read plasma flow. And so with plasma flow, it's PAH. But for renal blood flow, we have to do a special equation, right? RBF equals ERPF over 1 minus hematocrit. And so the mistake that I made is I didn't do this step. So you're absolutely right. So we would put 750, what we calculated for the clearance of PAH, over 1 minus 0.5, which is 50%. That would be 750 over 0.5, which is equal to 750 over 1 half. You flip that over, that equals 2 times 750. So our answer would actually be 1500. Oops. Good call, Natalia. Yes, you were right about that. Renal blood flow versus renal plasma flow. I got to be careful, obviously, right? I'm the one giving you the question, and even I messed it up. Renal blood flow. Usually for renal blood flow, they're going to give you 50% for the hematocrit. And that makes it easy to figure out what the renal blood flow is from plasma flow. You basically just double it. You multiply it by 2. Yes. Yeah. 0.5. Yeah. Same thing as 50%. Yeah. If you see this 50% and they're asking about blood flow, just multiply whatever you get for RPF by 2 because that's ultimately what you're going to do in the end. Okay. Great. 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 Okay. Oh my God, this is so tiny. Can you read this? I can make it bigger. Okay. Right. Good. Good. Yep, I agree. It's okay. So, that's okay. So, it's very specific. This is one of those you know it or you don't know it, right? And so we have a young male. He has blood in his sputum and blood in his urine. When you see that, I want you to think about Goodpasture syndrome. There's a lot of different ways they can confuse you on step one, but they can't really hide this one. And so whenever you have a young male, blood in the sputum and blood in the urine, that is going to be Goodpasture syndrome. Okay, so with Goodpasture syndrome, you have an antibody that binds to basement membranes. Okay, so that antibody is going to bind to the basement membrane in your kidney and lead to hematuria and your nephritic syndrome. And it'll do the same thing in your lungs, leading to that blood in your sputum, hemoptysis. And so seeing those two things together really should point you towards Goodpasture syndrome. They don't give you anything else to give you to point towards another disease. And so, which of the following of these antibodies is consistent with Goodpasture's? Oh, that's okay. So it's going to be our glomerular basement membrane antibody. And so literally, it's just an antibody that binds the basement membrane. Okay? If you have an antibody that binds the basement membrane, it's probably going to break the basement membrane and cause all of that blood to be exposed. Okay? Our ANCAs are ones that we see in our Wegener's disease. And so C. ANCA is seen in Wegener's disease. With with Wegener's disease, what you see is bleeding from the nose. Bleeding from the nose. So if you see your patient not with hemoptysis, but just blood from the nose, that and blood in the urine, that would be a Wegener's syndrome. Okay. And with P-ANCA, this is polyangiitis. Here we have a much different presentation with, sort of GI problems and but also blood in the urine. Okay, and so these ones are out. Antiphospholipid antibody. This is seen in lupus, SLE, and this causes clots. Okay, so when you have an antiphospholipid antibody, you have an increased risk of clots. DVTs, pulmonary embolism, strokes, things like that, you will see if you have antiphospholipid antibody. And anti-double-stranded antibody is our anti-Smith antibody, which we also see in lupus. Right? Double-stranded antibody is lupus? This anti-double-stranded DNA antibody, that's lupus, right? I don't know why this is not popping into my head. Anti-double-stranded DNA antibody is lupus. Okay. Whew. I was getting nervous there for a second. So this one is lupus. Antiphospholipid antibody, also lupus. This one is our Goodpasture syndrome. Again, look for a young male with blood in his cough and blood in his urine. Okay? Some of these it's just going to be memorization, making flashcards, and just reading again and again so that you remember it. Okay? Because, it's not like some of those other questions where you can kind of figure it out or, use your logic to figure it out. It's you either know it or you don't know it, unfortunately. Okay. This is a tough one. So what are you thinking is wrong with this little boy? Why does he have that fever and flank pain? Good. Yes. Yeah, definitely. He has some sort of UTI, right? And because he has pain on that, he has the CVA tenderness, right? CVA tenderness means that the UTI has gone up all the way to the kidneys and is now affecting the kidneys. And so good. So we know, sorry, go ahead. Yes, that's right. Good. And so that's the first sort of first step is to find out it's pyelonephritis, and we see the white blood cell casts, which works with that too. And so now we get into these really crazy descriptions of what we would see on biopsy. Okay. So I think the best bet here, and just kind of looking at this, is to try and eliminate any of these that you think don't make sense. And so I'll go first, and then if you see one you want to eliminate, you tell me, and then I'll go, and then we can see if we can get to the same answer. So the first one that I would pick is this segmental sclerosis and hyalinosis. This sounds more like when you have hypertension. With hypertension, you get sclerosis of some of those arteries, and you get hyaline in the walls of the arteries. And so I really don't think you would see that with pyelonephritis. What do you think? Yeah? So let's take this one out. Okay, your turn. Yeah, good. So normal glomeruli, accumulated lipid and PCT. Yeah, I don't like this one at all. Good. Yeah, minimal change. Yeah, excellent. Good. Good. Very okay. All right. I see you. I see you. This E I don't like. Polygonal clear cells with accumulated lipids and carbohydrates. This is our clear cell carcinoma of renal cell carcinoma. Remember when we did that one slide on renal cell carcinoma, we said that there's two types. One of them had those big balloon cells. And so when they're describing these polygonal clear cells with accumulated lipid and carbohydrates, that makes me think of clear cell carcinoma. So I would want to take that out. What do you think? Agree? You concur? Okay. So now we're down to 2. That's 50%. That's a lot better than 20%, right? So of these two, which one do you like? I'm kind of torn in between them, to be honest. Yeah. I was thinking that too. I was thinking that some sort of allergy would give you eosinophilic casts. That's where you see eosinophils. Here, it even tells us that there's white blood cell casts. And so I don't know if those would be eosinophils. I feel like they would be more like neutrophils if this is bacterial. So I would take this out as well and just go with this C, slough tubular cells within the tubular lumen. And I think that makes sense too, because as you have these recurrent UTIs, you're going to start to have, death of those tubular cells. But man, that's a tough one. That's a tough one for sure. Any questions on this one? As you can see, renal is not really my number one topic, but I try my best. So let's do one more before I let you go. Good. Mm-hmm. Good. Awesome. Good. Okay. Good. Nice. Round of applause, Natalia. Very impressed. So focal segmental, it went. I mean, you have to know this stuff to eliminate it, right? At the end of the day, you knew it. So, focal segmental, when we did that slide, we mentioned that focal segmental is associated with HIV, right? And so good, so excellent, very good, very good. Focal segmental, very common type of nephrotic syndrome. You had to know it was nephrotic, and you had to know which of these are nephrotic. And so that's really the biggest hurdle in terms of getting through some of this renal path. Awesome. I'm very happy how we were able to end today. It really seems like you're really learning and understanding these renal disorders. So Monday, when we get together, we're going to be going through hemonc. I'm going to make some changes to the slides over the weekend, and so don't download them if you don't. Okay, just if you want to review ahead of time, review from first aid. And on Monday, the slides are going to look different, so I don't want you to like take notes or whatever and then have it change on you. Okay? You're welcome. Great. Natalia, have an awesome weekend, and I'll see you soon. Okay? All right. Good night.